And next, we're going to turn to Congressman David Schweikert from Arizona's 1st District. Welcome. How are you? Good to see you. Thank you for joining us today.
I was told I didn't have a choice.
Well, so again, since I put him on the spot with a very in-the-moment news question, I wanted to start with you. We understand later today, this morning, House Republican caucus is going to be meeting about health care. The Speaker had promised perhaps a plan dropping this week. Can House Republicans...
Yeah, first, I don't think that was the plan. I think actually sort of building the process. Like, we were in meetings last night. And everyone and their cousin wants to reach back to the 1990s and HSAs and, association. And look, associations are great. And look, one of the reasons I'm probably sitting here is I chair the Joint Economic Committee. So I have actually a couple guys with PhDs that their whole life is healthcare math and statistics. And we've come up to a conclusion. We've turned healthcare into financial engineering, not healthcare. Think about the discussions you're going to have today with people, idiots like me sitting here. We're going to talk about, should we subsidize the subsidies? Should we move money here? When will there be the discussion of, should we legalize the technology? Shall we, the access to glutides, the access to cures, the access to these things? We live in a time of miracles. What are we doing to change the cost of healthcare by helping our brothers and sisters be healthier? We're working on a model right now. We're mining data for my state's Medicaid system. And we're looking at a data set that the majority of folks in my Medicaid system are obese. What if we could help them be healthier? And we're seeing some models that say, hey, in a couple of years, you might actually cut the actual cost of my Medicaid system by 25%. We don't talk that way because, let's be honest, the army of lobbyists, the others, want the cash. They don't really want to engage in the discussion of healthier populations because there's less cash.
Right. So just to take it one more step in the moment, where do you see the enhanced ACA credits going? And are you happy with your leadership?
I will do everything I can to oppose them.
To oppose them.
And it's the reason is if someone will just stop and look at the abstract. Here's my population that were already getting the subsidies. With the enhanced subsidies, you had last year in the 2024 year, 41 or so percent had no payment at all. It was completely subsidized. You basically look. The ACA is a financing bill. The Republican alternative was a financing bill, just a little better actuarially. Medicare for All is a financing bill. Who pays and who gets subsidized? We don't have the conversation of what we pay and why we pay it and the legalization of technology. The thing you can blow into, a breath biopsy, that's statistically more accurate than a human doctor, tell you if you have a viral infection or a bacterial infection, could order your antivirals. Except we keep that illegal. And that technology has existed for a few years. And when I've offered the legislation, I get an army of lobbyists that come in and say, David, but the same thing we went through with telehealth. It was never, ever, ever, ever going to get a hearing until the pandemic hit, because it would stop people walking into the urgent care centers, the emergency rooms, those things. We don't have the brutally honest discussion of when we talk about the misalignment of incentives. It's also the incentives of how we finance, and that we've turned healthcare into financing, not health.
So a hard no on the subsidies, and you're looking for...
Now, I'm willing to have a discussion of using some of those monies to legalize technologies, to bring technologies to market that would actually lower the price of healthcare for everyone. It started as a thought experiment, and then we dove into the data. We think we spend 25 to 35 billion a year in duplicative MRIs, X-rays, ultrasounds, CTs, a year in government payment. So if you want to do something moral, you get your MRI, attach it to this damn thing. And then 2 weeks later, when you're at your other specialist and they want to redo it, say, no, I can just hand it to you this way. Except I already have folks trying to stop that. It's examples, and think about that. That's almost as much as the enhanced subsidies. So we don't actually think through the actual problem. We're going to have a debate of hand out more money and borrow it. Remember, this year, every dollar of tax receipts, we spend $1.43. Almost every dime of health care that comes through government is now borrowed.
You're a big digital health champion, and including more AI in care delivery, since we're talking about care delivery. What do you say to people who are concerned about sharing their personal information with a generative AI platform?
Well, so I have my finances. The fact of the matter is, if you carry particularly the Apple phone, which I know well, your personal data is behind the encryption chip. And so think of the idiocy we have in this conversation. My health records are in a paper file at my doctor and being faxed around, or I can have it encrypted, and whether it's oral ring, I experiment with wearing a Dexcom glucose reader. Found orange juice does weird things. But the fact of the matter is the acceptance of I could be autonomous. The fact of the matter is I can almost wear my own medical lab today. When the Apple Watch is now FDA approved, the next generation, for heart, for a series of heart things, should it be allowed to prescribe within its areas of competence? Interesting question, because if we would do that, could you imagine the capital that would move into the revolution of automating parts of our healthcare system? And then we have other things, clean claims. Your doctor, here's their notes that were recorded. Here's the insurance contract. The AI says, yep, they match, and it's paid. You don't have a group of billers in the back of the room and a group of people denying it at the insurance company. That's not complicated. It already exists today. But the people who sell the billing services are pissed off that you're trying to make healthcare less expensive and more accessible. We live in a time of a revolution. We're having the wrong debate because this debate over here may not have as much cash flowing through it.
You mentioned obesity and the effects it has on broader healthcare spending. Where do you see GLP-1 coverage a year from now, both public and private?
We wrote a report 2 years ago, and we thought we were going to get our heads kicked in. And it took us months and months and months and months and 3 PhDs writing it, but we did an analysis of what does obesity cost. And we came up, this is 2 years ago, $9.1 trillion over 10 years in additional healthcare costs, making it functionally the most expensive thing in America. And we published it, and oddly enough, my friends on the left, the right, academia, they loved it because someone was finally willing to actually have the conversation about it. Now, I'm a bit more, can you imagine, annoying on this. I actually think it's also a discussion of what we do in agricultural policy, in nutrition support policy, in all these things. But we made a prediction in that report that in the next couple of years, the price of glutites would crash. As you know, you've all seen it published, we expect a tablet form available the end of spring that may be as little as $145 a month. If that is true, we're on the cusp of a revolution. And yet we should really think this through of how it could be used in society to help our brothers and sisters be healthier and deal with their misery.
You are leaving Congress to run for governor of a very key swing state. So you have a real interesting perspective, having gone through the budget reconciliation this year. If all things turn out, how would you deal with the downstream effects of the big, beautiful bill? The federal Medicaid cuts, the increased obligation to fund SNAP benefits. How do you do that without blowing a hole through your budget?
Well, actually, in some ways, you almost never get innovative unless you're pressured. Remember how I just told you we were doing some of the data mining on my state's Medicaid system? And as a young man, I did its budgets. As a child, I was a page in the state Senate. Arizona uses a unusual, we buy managed care policies for indigents. That's our, what we call Axios, our Medicaid system. I will argue your question on even, let's just use one sliver, the access to glutides, GLP-1s, may be one of the ways where you could lower the cost of your Medicaid system by almost a quarter. We also have been looking at other types of technologies that are available. The wristband that helps us manage your ups and downs. Using a silly thing, I have two adopted kids. Both were born on my state's Medicaid system to a semi-homeless woman. She had no prenatal care. And we talked to her, and she said, well, I didn't know how to get to the hospital. But she had a smartphone. We could have just made it so, okay, here's your ride. There's just dozens and dozens and dozens of things that we in our lives sort of take for granted that for that population we can make available. And we've been looking at the statistics of lowering bad outcomes, and it's the bad outcomes that are outrageously expensive. You know, when 5% is 50% of your spend, how do I make that 5% has less major events?
One last Arizona question. We're almost out of time. I did want to ask, since you have a unique relationship with the tribes, how are they going to be accessing the rural health money in the big, beautiful bill? Because
that's actually a brilliant question. We're trying to actually go further than that. We've been actually trying to have some discussions with some of the leadership of IHS and some of the tribes themselves. Like, you know, right now, you can't use IHS monies, and a tribe can't use managed care. You know, so you can have this very robust network, particularly with your suburban, urban tribes. So we're trying to rethink how IHS, some of the rural hospital money, some of the, remember, tribal enrollees often have multiple health care. Here's what's provided by the tribe, here's what's provided by IHS, here may be a private insurance contract. It's more complicated, and trying to streamline those multiple payers for those populations. And then you have things like the Navajo Nation, which is like its own country, where here you'll have a hospital that's actually just owned by the tribe. And so it turns out you need a whiteboard and a bunch of ink pens to work through all the different payer sources and the population. But you also have to deal with reality. I have one tribe I represent. It's actually a fairly wealthy tribe. Per capita income is almost the same as Scottsdale. And their life expectancy for a male is around 54, 55 years old. Mm-hmm. It's diabetes. They lack a certain enzyme to break down sugars. And so the arrogance we often have of, here's our one size fits all, and not understanding the uniqueness of the genetics of some of the populations we are here to serve. And my challenge to you as reporters, but also the idiots, people like me that are elected, I'm in a 50-50 district, and I run on talking about healthcare as a conservative Republican. And I get reelected because it turns out Republican voters are also interested. Independent voters are also interested, and Democrats are just befuddled that someone's willing to actually walk through the math and how it works. The problem is it's hard. It takes lots of reading and studying to get to know it. But I don't know why it's so polarizing. Healthcare is consuming, interest in healthcare are consuming the finances of this government. We got to step up and deal with it.
Well, I'm sure we could spend a good part of the morning, but we are out of time.